We are going to go ahead without further ado with our next roundtable. Situation in Spain, 10 years of evolution. We will have Dr. Rubén Quintero as a moderator. He is a doctor for GUETS, for the emergency unit in Guadalajara, and he also is part of the GUETS in Gigante 2 in Guadalajara, in Ciudad Real, sorry.
Doctor Rubén Quintero tiene la palabra. Buenos días. Bueno, pues vamos un poquito de tiempo. Voy a dejar hablar a los que realmente saben de transfusión. Tengo a mi lado a mi compañero, Roberto Estévez, uno de los titanes, uno de los fundadores de nuestra transfusión en España.
We have colleagues here, coordinator of the 061 number.
Bueno, si nombramos su currículum, nos tenemos aquí toda la mañana.
Well, we could talk here all morning if I went into their background and their experience, but, well, basically we have Paco Gallego, an emergency doctor with us, working in Malaga, a founder of the emergency transfusion program in Andalucía, and we're going to be hearing about the programs that they have in their regions. There are 17 regions, as you know, in Spain. And I'd have to apologize on behalf of Jessie Guillen because of unforeseen circumstances, she really cannot be with us. And I will give her talk. So whenever you're ready.
Hola, muy buenos días. Un saludo a todos, lo primero.
Good morning. Welcome to everybody. Greetings to everybody. Thanks to all of my colleagues. The organizing committee decided that I would have the privilege, the honor of talking about pre-hospital transfusions in Spain. So thank you very much for joining us. And first of all, what I'd like to say that this is what we're going to be talking about. We're going to be talking about pre-hospital transfusion in Castilla-La Mancha and how it's been spread a little bit to the rest of the Spain. This is what we have. These are our colleagues working, all of them. We've got doctors, nurses, pilots, mechanics, because, as we'll see, pre-hospital transfusion is very closely linked to the use of helicopters, both in Spain and internationally, because it can get there very quickly, it can attend to them, it can stabilize them, and it can take them quickly to the healthcare center. And we've seen in many articles that, in the end, what really resolves the problem is in the hospital. We can get a correct diagnosis, a massive transfusion, and surgery when they're in the hospital. So what we have to have is a substrate which is good enough to maintain the patient and in order for other professionals to be able to take action. And here we're talking about the hospitals, and normally we're talking about central or trauma hospitals that they're taken to. This is, well, an idea of some of the articles we've read to prepare the talk. Some of them are more and less recent. All of them are very interesting. Even the guidelines that we're looking at and that we're using in the different health services, prepared by colleagues and based on evidence. This is what we have right now. Many of the elements that we use: helicopters, time, coordination, surgery, and blood. But there is a lot more involved. All of these elements can be used to benefit the patient. We use more and more elements. It's becoming more and more technical. We give them better service based on evidence. And then we find ourselves in this situation. Well, we go from the micro to the macro. Now I'm here to talk about the macro part. These are the things that we come across. And, well, we have the doctrine of damage control, as it's called. This is something that's existed for a long time. Since the first Gulf War, the Americans began to talk about this damage control doctrine with 4 different phases. But we are going to focus specifically on the first one, which is the pre-hospital phase. The rest is for the emergency team in the hospital, the people in intensive care, surgery, and recovery. That's what's inside the hospital. We're just going to focus on the first part, the damage control resuscitation. We have permissive hypertension. We try to maintain trauma levels within, well, within average blood pressure. It's true that with a pure approach, it can go a little bit up to maintain the pressure in the brain. And we have hemostatic resuscitation. And here we're talking about red blood cells, packed red blood cells. And it's important to have this slogan in mind. We must maintain the patient in the best possible conditions so that other professionals can take action on them. And we should not delay the transfer to the most useful center. In other words, we're like the rabbit in Alice in Wonderland. We're always running around. We can be in a rush because we have to stabilize them and we have to then take them to a hospital. But in this beautiful region that we live in, where I've worked for many years, is that we have very large distances to cover, and where the emergency takes place maybe 40 minutes away by helicopter, over an hour by land. And this is an element which will be decisive. And it's very important in this situation when you're taking blood to a patient. It's very important to understand that as far as possible, we have to contain the bleeding in order to later on replace it in the most physiological way possible. And this is going to be the leitmotif. But if we contain or we limit in order to replace, and we want to replace it physiologically. All of these elements have evidence when it comes to controlling bleeding, above all for internal and external hemostasia or hemostasis. No, this wasn't the case 10 years ago. Not everybody had this in Spain or throughout the whole of the national territory. With all of these elements in all of the regions, almost all of these things are already implemented, and many of them are based on evidence because it's validated on occasions by the official committee and the army. We're talking about practices taken from the army because they work, they've seen that they work, and I include this in the civil service. For example, an American Marine, well, that's one case, but if we're talking about a farmer in Castilla-La Mancha, in micro terms, they're very similar. In macro terms, they're not very similar, but at a micro level, they are. Besides containing the bleeding and hemostasis, we have to do replacement in a physiological way. We are working in a conservative way, hypertensive and hemostatic. We want normal thermal situation. We can use isobalanced crystalloids based on blood as an alternative to crystalloids, or based on vasoactive agents compared to crystalloids. So what are these elements we're talking about? We're talking about vasopressors and blood. So what should this be like? Well, besides this, well, we said we don't have a way of replenishing the patient. I mean, this was when we looked at it, first of all, 11 years ago, we had perfusion pumps and physiological saline. And we said, well, we could take a leap forward. We could take blood from the hospital and take it out onto the streets. And that was our experience. But we didn't discover this. What we did was to copy and implement and adapt it to the context of Castilla-La Mancha, because we knew that there was other people elsewhere doing this. And we said, for the best interest of the patient, we decided to copy it, replicate it, and then adapt it to the Castilla-La Mancha setting. And well, this was due to a crisis situation. Well, we had several cases of young people who bled to death, either where we were dealing with them or when they reached the hospital. And we said, if we use blood and other elements, could we lengthen that time in order to get them to the surgeon in the hospital, to get them to the definitive treatment? So we use these crises as an experience to encourage us to improve. Here we have one of the cases. These are one of the cases that led us to that idea. And who's doing this? Well, the Australians, the British were doing this. And what did we say? Well, we said we could try to bring their elements to our project. And here we have the map. There's, well, not enough room. We should include lots more logos, lots more symbols, because there are many other countries doing this. But over these recent years, almost everybody around the world, almost everybody, the Swedes, the Germans, the Americans, the British, Italians, everybody does this transfusion, either with whole blood or with plasma or packed red blood cells. But they do this with hemorrhagic patients. And we knew it was safe to transport because we read the articles. But what we did was we tried to test it to make sure that what we were doing was safe for the patient, mainly because in our collaboration with the blood bank, we worked as a team, and they asked to know that the blood was going to be well looked after and that it was not going to be affected. And basically, sorry, we had our experience. Here we can see it at the bottom. There we can see it. We published this with controls and checks. We left some blood in the hospital. We took some out on the air helicopter for a certain amount of time. We studied the vibration, the thermal impact, and we saw that just as other people had seen elsewhere, it was perfectly fine. We could do that without any problems, and it was safe. It's true that we have improved and worked on maintenance for the blood. It's generally true that we have to keep that blood at all time at the right temperature, according to national and international standards, and we change the packed red blood cells once a month, generally, as a rule. And as Elena said, we don't throw tissue away, we don't throw the donated blood away. It's got to be used for patients. So what do? We have an early delivery, 8 days, so that that blood can be taken back into the hospital circuit and it can be used. We do not throw any of it away. We cannot afford to throw it away. It's very valuable. And in Ciudad Real, we can transfuse even at night time. And this is very interesting because 2 minutes left. Okay. We can do this during the night. We've had to create documents very similar to what you use in the hospital when it comes to a transfusion. Indications, it's indications or a checklist which is specific, and we always follow the valid regulations as are applied to blood transfusions in a hospital and in the blood bank. We have certificate from health inspection services, from the regional health services. This is very important, and we take into account these 4 elements. It has to be traceable and safe. There has to be a control of temperature and quality. We have very clear transfusion indications and information, and we have clear ethical and legal conditions. And obviously, we have to take into account all of these things. In our experience, we have seen that this has been taken to other regions in Spain. We began with this. This was what was kind of the low-cost version, you know, like the supermarket brand. And we've evolved to something much more technological with greater controls and something which is much better, with more capacity for conserving the blood and for tracing the blood. And there's another aspect is that often we're working in the summer. For example, if there's a fire, the helicopter will be taken close to where there is a forest fire, and we can stay there all night in case the forces have any problems. So sometimes we've needed bigger coolers. We had to keep the blood off base for maybe 15, 20 years sometimes on this occasion. That was the most important technological development. It's also important to understand the target patient. You know, are they bleeding and they need it? It's very important in this case to activate all of this from the coordinating center as early as possible, and that's what we're working on right now. And I'd have to say also, I don't want to go into too much detail. I would talk about some specific cases, although other colleagues are going to talk about other triggers in order to decide when transfusion is appropriate. But we use the shock index, although as far as possible, we try to use ECOFAS and anatomic criteria as well, and the portable analyzer. There are many articles that tell us that the capnography can help us to identify who we should transfuse. We don't just do it in a crazy way. That's a photo of a colleague. And here we come to the shock index. This is quite a sensitive tool. It's very useful, although it needs improving with extra elements for other triggers when it comes to transfusion. If we think of a pediatric patient, for example, it's interesting to have it as a tool in order to identify which patients are suitable for transfusion. Right now, according to the last information, we have given a transfusion to 127 people who have benefited from this therapy. More men than women, generally traffic accidents and accidents at work. We've also had digestive hemorrhaging, which is the medical pathology that we've seen the most. We've also had autolysis and vascular ruptures, which are subsidiary. We've dealt with patients at a distance of 9 kilometers right through to 250 kilometers. And also we have transfer times to the useful center of between 7 minutes and 150 minutes by land, ages between 12 and 97 years. And we give a transfusion to whoever needs it. We don't leave anybody out. And improvements. In this case, besides the packed red blood cells, when we have trauma patients, we give 2 grams of fibrinogen, and we see that another element that we have is that hypoglycemia can have an impact on the hemorrhaging, and so we have a triple therapy. We give red blood cells to transport oxygen, and helping with the clotting, we have fibrinogen to try to clot, and then we have chloride or calcium gluconate in order to reduce the impact of coagulation, and we help with that coagulation cascade. We hope, to have whole blood as we see abroad, but obviously we have to work hard in order for this to be a reality. And this is what we're all hoping for. Obviously, and we always say this to our colleagues, if you don't have blood, think that we do have it. If you need it, just call us and we'll go. Obviously, this has to be done via the coordination center. We have a flying blood bank that's available to the entire region. I hear of some of the cases we have responded to. Some of them, we had Dr. Pacheco, in fact, was involved. And I would just say that our objective will continue to be, and has always been, caring for the patients with the best quality and based on evidence using the resources available. Pre-hospital transfusion is a feasible reality. It's based on evidence, it's cheap, and it can be applied in our regions. Without any further ado, that's it. Thank you.
Había que correr.
Ahora. Muy bien, Roberto. Tiene la palabra doctor Gallego, que me va a contar el sistema de transfusión.
Now we have Dr. Gallego. He's going to talk about Andalucía. Hello. Good morning to everybody. Thank you very much for inviting us here and for giving us the opportunity to tell you about Andalucía. We have been the latest region that's begun with pre-hospital transfusions. We are students, like everybody, students of Castilla-La Mancha, our host today. They have been our masters in this, teachers, and Dr. Muñoz, indeed in charge of this, Rafael Muñoz from the nursing side, has been really involved in the introduction of all of this in Andalucía. Right now, as you know, we have 3 regions, Aragon, Castilla-La Mancha and Andalucía, 2 helicopters in each. In Andalucía, we are aspiring to having blood on all of the helicopters in the region. as soon as possible. And soon we will have the third one functioning. This began in 2021 when the project was first begun. And I would like to say that it actually began a little bit before that. In 2016, I was working here in Castilla-La Mancha with Gigante 2 and Gigante 2, that helicopter. And that's where I learned from the experts. I learned about what they were doing, and I decided it needed to be taken to Andalucía. And a few years afterwards, in 2021, we took our first steps. And in Andalucía, we had the 061 phone line authorities involved. We had involvement of Huelva and Malaga with the Malaga helicopter, which was amongst the first. And in this project, well, we took different steps. First of all, we had validation. And I'll run through them because they can be useful for people who are thinking about doing this and listening from other regions if they want to introduce this. This will help them to see how we introduced it. We did it, as I said, through validation. We're looking at the materials, making sure there was no contamination, no hemolysis, and we followed the chemotherapy standards that we can see here. This was in Andalucía region, and the following step was very important to give training for people in transfusions. I mean, the people who are going to actually have to do it, that's very important. And then we had the definitive procedure, and we had a pilot project with the first patients, so that in 2022, 1 year after starting the project, the Malaga helicopter became the first base, the extra hospital base, which was certified as having this capacity for transfusions, but also to transport and be a deposit for blood. We had operations that I will explain. These can be useful for people thinking of doing this in the future. So what do we have? We have a non-transfusional phase, which is at the base. This is from the moment when the blood is received. It's a deposit for the blood and it's checked. We have to make sure. The law says that we have to double check that blood. We then store it. We check the blood group. Then we have the storage where we have a daily check and we check for expiry dates. And in transport, we have 10-minute checks on the temperature, even during transport, as I said. And then we have the transfusional phase with the patient. One part is the actual act of carrying out the transfusion, obviously adapted to the situation out of the hospital. And then at the hospital, we have to provide the tests before the transfusion, the blood samples, and the replenishment of the red blood cells. Here we can see everything related to the storage. And on the wall here, we can see we have some infographs. These are very important because, well, we're talking about an aeronautic kind of setting, and the pilots always have checklists. They check their helicopter using this checklist every day because there are things, well, that don't happen every day. We have a transfusion once every 28 days on average, and we have to prepare for everything that might happen, right from the base through to the transfusion. We have this checklist to make sure we have everything we need, no matter what might happen. And so we have to have the cooler, which is always closed and refrigerated at 3 degrees. This shouldn't depend on electricity supply. And if we have a power cut, it doesn't matter even if we're talking about the winter, for example, when the helicopter is 12 hours off base. But nonetheless, we have seen that that cooler works and we maintain those 2 to 6 degrees. If we're talking about the temperature, as I said, it's 2 to 6 degrees during storage, and it can vary from 1 to 10 during transport. But we never actually leave this interval of 2 to 6 degrees. Even when we're transporting, it's the same storage temperature. So we have greater leeway. And then we have this interchange, or the exchange of the unused blood 10 days before it expires. And there are blood tests to check the group. We've seen with experience that when the thermometer of the probe tells us 4.3, we change the refrigeration system, and we have other coolers inside, and everything is changed because there is inertia in the system. So when you come back from an alert, the temperature continues to go up. And we never reach 6. We always change the whole refrigeration system before we reach 6. Here we have the transport, we have solidification. I mean, freezing is never used. It's always above 0 degrees. It's 3 normally, and it's stabilized at 3, but it never goes below. We can see this. It's very simple cooler that we've used. Well, the manufacturer created it with 2 of these units or blocks, but we modified it. With this box, we close it, we have a lid, we modify it, and this is taken on all of the flights. It's small, 2.7 kilos in weight, and we can see how it fits behind the seat. It's a small helicopter, so we have to make sure that everything's compact. Here we can see 2 cold stabilizers. This is a fridge, and we have a reserve fridge in case we need to change. And it's always between 2 and 6 degrees. As I have said, it's always between 2 and 6. And we have these probes that check. The probe is between the bags. It registers the temperature every 10 minutes. And when we're going to carry out a transfusion, it's in a pack. We have a pack prepared. And here we can see the fridge, and on top of it, there's a bag where we have everything we need for the transfusion. We have the checklists that we think are necessary. We think it's necessary to have a checklist in order to make sure there are no mistakes. No mistakes there. We have the warmer. We use this in, we saw this in Castilla-La Mancha with those experts, and then the other usable products. Here we can see the checklist in details. That's one of the first versions. I think we have a later version, but we can see everything regarding the actual transfusion itself, step by step, everything you need for the actual transfusion. There's another one for the delivery of the pre-transfusion test or sample, and then we have post-transfusional replenishment and special situations if the patient dies before reaching the hospital, or if there is a bag found to be deteriorated, although we've never had such a case. And just like in Castilla-La Mancha, we give fibrinogen, 2 concentrates of 1 gram. And I would say it's very important to make sure we're giving a transfusion to the right kinds of patients. We have 2 scales. We have the shock index. This is very sensitive, but not very specific. So we also try to use the ABC scale, which adds ultrasound. That improves specificity. And if we have time, since we have an analyzing system, we can use FAST. We look at hemoglobin, etc., and it can be made more specific in order to choose the patients. Right now, we have given transfusion to 38, 33 in the Malaga helicopter, and 5 in the Granada helicopter, which is more recent. We'll also see 1 in Seville. Right now, we have an average of 1 every 28 days, and 92% of the transfusions are severe trauma patients, but, well, we also have had childbirth, hemorrhaging after childbirth. We've had an aortic aneurysm and digestive hemorrhaging as well. Of the patients that we've had all of those experiences. We've had 37% mortality rate. That's something we need to look after. If we have a very minor patient, it's not really going to have a significant impact if we give them a transfusion. And if they're very, very severe, similarly, it's not going to have any impact. And the average age, 45 years from a road accident. And so far, we haven't seen any complications, no reactions. We've never had any problem or deterioration with the bags. And all of the bags that have not been used have been returned to hospital use. 2 minutes left. Okay, I'm finishing already. We carry out, we have health authorization and records, and we have internal audits and external audits from the department. So the procedure that we've developed for transfusion outside of the hospital, we consider it to be very safe. And as I've said, it's reliable, and it's given us quite an economic solution. I think we can say that we are creating opportunities for favorable outlook for all of our transfusion patients after looking at, I mean, obviously we would need to look at larger studies, looking at larger number of patients. We believe in this, of course, but we need to back it up with evidence as the numbers go up. And I would also say that the rigor and the involvement of all of the professionals has been fundamental. The blood is important, but what's really important are the people to take it out to the patients. And we have this project for the future to take it to the whole of Andalucía, to have 5 helicopters in Andalucía. We hope to have that very soon, and we would like to improve and take other blood products. And whole blood hopefully will be one of them. And here we are to learn about how that can be done and how to help patients. And in the long term, we are thinking of including and working with ground units that are far from hospitals to give them the possibility of transporting blood. Because if we can do it in an air vehicle, we could include them and we could take it to more of the population. Here we can see other events that we've organized and other people working on this, because what is behind all of this is what really creates value for this project. Thank you very much for inviting me here. And if you have any questions, I'll be very pleased to answer them. Thank you.
Vale, vamos con el turno de preguntas.
So let's go with the questions. If there are any questions for Paco and Roberto, maybe you made everything so clear that no one has questions for you. I don't know. Oh, yes. Yes, we do have a question.
Buenos días.
Good morning. I'm José Díaz Valdés. I'm part of the Gómez Ullas Hospital, and I am a hematologist, and I would like to congratulate you in terms of how impressive your presentations were. It's very moving to see all of this work. And what I would like to ask is, I am a very full believer in pre-hospital transfusion, and I have read a lot of literature about this, lots of papers from our colleagues, and saying that this avoids deaths, unnecessary deaths. So what I would like to know is, how do you tackle reaching a hospital where there's a massive transfusion protocol? Because we have to change this way of thinking, I would say, because this protocol should start at the pre-hospital level, and it's important to internalize this concept, because for me, pre-hospital transfusion is like as if at emergencies at a hospital, we wouldn't start with the transfusion because we have the operating room just there, so we will do it there instead of doing here at the emergencies. So it's important to be very aware of this. This massive transfusion has to start at the pre-hospital level, and what for me would be ideal would be to use whole blood for this, but if we can't, we should have fibrinogens, as we have talked about, also help with calcium. Yes, of course, and from my point of view, I would like to act as in any other countries where we can use this pre-hospital transfusion at a street level, but we can't right now control that. In London, we can even find anesthesiologists at the street level, and everything is controlled for when the patient reaches the hospital. So I would like to find whole blood as well, packed red blood cells, every option, but I have to act with what I have at hand. I would like to be like, for example, like as they do in Texas. But for now, we do what we can, and we need more coordination, more people, more resources, and I wish that I could honestly implement this massive transfusion at the pre-hospital level, but as of today, we don't have the option, sadly, and I do agree with you, however. Well, in our case, what I must say is that when we started with the trauma protocol, we did have some scores, objective scores that we used, and when we are going to start with resuscitation, we do find that the red blood count is already there. So thanks to our study, because we had the concession from the bioethical committee, we found that we have a total of 27 patients already. So I think it's quite a good number. First of all, good morning and congratulations on these fantastic presentations and programs you're carrying out. And what I would like to add is that our colleague from Gómez, the doctor that made the previous question, is that he was talking more about the criteria that we sometimes use. I can't agree with using the SOC index for this matter, for example. I don't think this should be our protocol. I think we do have some other possibilities that we can use for evaluating the loss of blood in a better way at a hospital level and pre-hospital level. And when there's a trauma code, we have to follow, obviously, the criteria that coordinate us with our hospitals, of course. And if we have to implement TARs, well, we will have to do it. But if we can avoid to use the SOC index, it would be better, I think. And yes, in fact, we have talked about this, and we have said it before. We always try to use a different scale because the SOC index is not very precise. So ideally, we should be able to use the TASH score, the trauma-associated severe hemorrhage score for this. But we have to manage time. Yes, of course, managing time is key. And also human resources. We have to manage everything. So obviously, there's something that is quite clear. The patient is stabilized. We usually use only 2 people for all this job. So sometimes it's very complicated to carry out all of this. We could try to run an analysis in flight, but for only 2 people, it's sometimes very difficult to act fully when trying to treat 1, 2, even 3 patients. Maybe we have a person still waiting inside of a car after a car crash, and without a higher scale, obviously, we don't have all the details that we would need. But obviously, we would want to use this TASH, but sometimes it's not possible. Sometimes we treat patients that are 40 minutes onwards after post-trauma, and those 30 key or minutes or the 15 diamond minutes are already gone when I arrive sometimes. So I have to be fast. And of course, I do agree when it comes to trying to be as precise as we can as well. Thank you very much. Thank you very much. Thank you for that fantastic presentation. My question is for Dr. Gallego. I think it's very important because you mentioned something, but then didn't go more into detail. We are talking about trying to implement in some of the terrestrial units this transfusion. Sometimes we have seen in for example, in the United States that they try to implement this system in other units as well. We have seen some problems of equality. We do have to work towards trying to erase those inequalities, and I would like to know which would be the terrestrial units where this program could be implemented, in your opinion. For example, in France, we have seen already similar experiences, and I don't know which would be your criteria for this. Well, it's true that when it comes to trauma, we have been talking about this, but we would be talking about units that would have a high prevalence of trauma patients, and then terrestrial units that would be too far away from hospitals. Because some of them, and I'm thinking I have one in mind in particular in Marbella, where they do treat many trauma patients and are quite far away from the closest hospital, and the transferring times for patients are usually around 45 minutes. So this could be a perfect candidate for implementing this program. And then we go back to the human factor, because of course we cannot lose blood in terms of misuse it. So we have to try to have motivated people working on this. We have to try and keep our teams small and motivated, so there's always a risk there when growing, because we are very well cohesionated. And we have to have all the factors, the human factor, the distance from the hospital, and the treatment of trauma patients. Yes, and I would like to add that at some very big capital cities, we find that some units have already talked about this. For example, the SAMUR unit should probably have this possibility, and SUMA as well has already thought of this in Madrid, and it would be an option, of course, but obviously in Valencia, Sevilla, Valencia, we could find patients that would need this service at least once a month. For example, at Basque Country as well, we could find the situation. Maybe we could be able to extract blood even and take this blood to the rural town where something happened. So obviously we will find traffic accidents, we will find car crashes, and these patients could be perfect candidates for this.
Hello, I'm Víctor
Fernandez, and I work at the Gigante 3, one of the helicopters from the HEMS. And I would like to thank you all for this incredible day and event. And I would like to bring back a memory. A colleague that we lost in 2020. We have seen him in many of the signs for this event. And then I would like to ask about the capnography, because we have talked about cardiac output, we have talked about other factors, but maybe you could give us some parameters in terms of CAT values or other factors that could affect the capnography. And then I would like to ask about hypercalcemia as well, because sometimes I have this doubt of what's happening at the hospital with the calcium. Is it good to transfuse with like enriched with calcium or not? First of all, I would like to say that these questions are very interesting when it comes to the capnography and also the calcium. Well, first of all, sometimes the parameters that we use are changed from one patient to another. The speed of the transfusion is also important. We have to put this into context because we have a patient that finds himself in an hemorrhagic shock, and maybe we have a scale where we can find TASH and canography, and we can have extra information on the state of the patient, and we have to bear this in mind. But I can't give you a trigger, an exact point where you should carry out your transfusion. But probably we will have more important information on this later in the day. And then talking about calcium, obviously it's part of the protocols. Sometimes we do it blindly, right? But I would say that if it's possible, we should run an analysis before doing this. And some hospitals have this measurement for each 2 packed red blood cells. They apply 1 unit of calcium, but obviously this affects the ionic calcium in the blood, so I can't really supervise that. I can't control this. At the hospital, yes, but at the pre-hospital level, we can't know for sure. So we are kind of hand-tied in this sense.
Tenemos una pregunta de parte de Pepe Bravo, uno de los asistentes en streaming.
Like to ask on behalf of Mr. Bravo a question coming from our stream attendees, and would like to know how to use or where to hold the hemoderivatives bag, if it should be at the hold of the helicopter or not. Yes, well, it should be as protected as possible and out of the sunlight. And in terms of calcium, we always run an analysis. If they are in a low figure, we do apply calcium, but if not, we don't. We try not to do it blindly. And then I would like to comment on an article that has been published 2 months ago, precisely on this, talking about the predictive level of EtCO2 with respect to the hemorrhagic shock. And there is a very significant relation, because some of the patients that had this hemorrhagic shock, they had values between 30 and 33. We can't establish a trigger point, but we can say that there's a huge relation when it comes to this predictor, even above metabolic factors. So some others were in 40, 40 some, so this value closer to 30, we find ourselves in a context of hemorrhagic shock, and we should introduce this concept. Yes, absolutely. It's very interesting. Thank you. Well, since we don't have a lot of time, we will finish already with this one.